See, the good part about e-ICU is that I am on clinical call for e-ICU today, and I'm here. So that's the beauty of the concept. And as Dr. Prachi knows, all the e-ICU team is actually currently in Singapore. We have an event there, and I am covering for the team till today night. But then the command center is still functional. Patients are still being monitored, and I have not received any call in last 4 or 5 hours. So that's the beauty of e-ICU. And as you are a believer in it, so I don't need to explain it to you, but this is how e-ICU is all about. So I'll just give a background of what we are. Right now we are an e-ICU group which is managing about 350 ICU beds all across India, including Bangladesh and Nepal. We have got 2 ICUs each in every country. We have got 12 cities covered in the country so far, and covering about 367 odd beds all across the country. What is e-ICU? Is nothing but a blend of medical technology, critical care expertise. You do need to have a passion to do this kind of a thing. Smart alerts and audiovisual. So these are the 4 pillars of e-ICU, the way we call it in the current scenario. What is e-ICU or what is tele-ICU? It's nothing but a critical care based approach of managing patients and strategizing and making SOPs to give critical care delivery to the distant areas of the country. It's nothing but a 24/7, 365 monitoring system where you assess the patient, you support the patient through electric records, audio visuals, smart alert system, which is basically coming out of a large command center. And Dr. Prachi has visited the command center. It's a clinically proven program. e-ICU started first in US in 1999 because they felt that the amount of effort that goes in actually producing outcomes in critical care could only be given by a intensivist in the ICU, but there was short staffed as far as intensivist is concerned. So there's a guy called Brian Rosenfield who started this pilot project of running e-ICU, and he proved that the outcomes would not different if I can actually run one of the ICUs through electronic mechanisms. And that's how e-ICU started, and at this point of time 40% of ICU beds in US are monitored through tele-ICU mechanisms. So it's nothing but a clinically proven program. A lot of medical data has been generated, delivering quality care at the bedside, improving mortality, improving morbidity, improving infection control rates, desired length of stay, and there are a lot of benchmarking that is done. It helps critically ill patients remain in the spoke centers. You know, the transfer of patients is costly exercise. More than costly, we all know that there is high mortality during ambulance transports, whether it's road or any form of transport. You can actually manage these patients at the spoke center with as good level of ICU care as you can do in our centers. But then obviously it has its limitations. So this is what my presentation will show: the gaps in current critical care medicine, process flows, impacts, academics and scientific publications that we have had till now. What are the gaps in ICU? This is the McKinsey report in 2012, that we have a more aging population. We all know that the amount of aging population we are getting in the ICUs is very high. High disease burden without any adequate health infrastructure in the country. The problem statement that is coming with critical care is about we have 5 million patients that require ICU care. With only 70,000 beds ICU available, we can create more beds. That's not a problem. As we know, funding in healthcare in India is coming at a more rapid pace than what we can actually use it. But the problem lies not here. The problem lies here. Less than 15% are actually having a dedicated intensivist. And it gets further compounded when we know that we are producing only 8,500 intensivists are there as compared to a need of about 50,000. We all know the physician ratio in India is very less. 6 million nurses will be required by 2020 if you have to meet the healthcare needs of the country, and 3 million doctors, not only intensivists but all kind of doctors. 10% of deaths which are preventable can be caused because of ICU mistakes. And I told you, growing population, rising expectation, rising chronic diseases. So the problem gets further compounded. So what is critical care? It's about 24/7 care, which enables monitoring, assessment and support to critical care patients. We are very much dependent on technology. We can't function without monitors, machines, because that's what e-ICU is all about. Urbanization and growing economy is leading to the rapid rise in affordability, better education, better awareness, and better patient expectations. And the patient will not expect that you can just see, though I don't have this facility, and then walk off. No, they are expecting much more from the healthcare doctors at this point of time. So as we know, there's a lot of gap between need and the expectation and the availability. So what is the problem is that the patients want affordable ICU care, they want better quality. Obviously, there's proven that availability of an intensivist leads to better outcomes. They want convenience of service and value for money. What the hospitals want is improved patient flow and satisfaction. Obviously, they have to have quality, the speed of outcomes, cost management, and enhanced credibility and branding. For the doctors or the administrators, they need smooth running of the ICUs, because that's what the key is. Volume, value for money, and obviously help maintain quality standards. And for physician, they want 24/7 care by the intensivist, early recognition of warning signs, because that's what we are. We do, rather than catching up in intensive care, you have to catch things early, catch them fast. You want SOPs and quality bundles implemented, and you want regular upgradation of the skills, because that's where the medicines are moving to. So this is what the expectations are. If you could look at the different stakeholders in the any telemedicine environment, but more pertaining to e-ICU. What is e-ICU? So I think, it's the need of the future, but now it's already become present, because we are functional for last 7 years now. We started in September 2010, and it fulfills most of the needs, although I will not say that it replaces the intensivist. Having an intensivist on board is the best way, but if you can't have an intensivist on board, this can actually fulfill the gap, but it will not replace the person. So we know the need, what we need, we know the gaps about the requirement of the people. What are the advantages? You can actually use a very small pool of intensivists to actually man a lot of beds. Now, we'll come to that how. It actually improves the quality of medical service at the same cost as it being delivered at the spoke site. So you're adding very minimal cost for the e-ICU. Why the future is there? Because government needs to support this to come up in a big way, and that is where the movement has to start. We don't have any government hospital now in our scenario, and we'll have a strong PPP focus where actually digital health can actually become a parameter. That's the future, but these are the advantages. What do you do? This is the command center. We shifted from a smaller one to a larger one, and I'll just share the screens with you. This is the audiovisual part of it, and this is the. Can I have the mic? So it's nothing but a system of computers. This is Dr. Shamit Gupta. He is the medical director for our e-ICU. So we get to see the patient data on these two comps. These are the audio-visual systems on which we hamper, and this is showing the smart alerts, few cameras to actually search Google or internet, because you may be confused and you can't imagine what variety of patients we see when we see in the peripheral ICUs. You have to completely change your mindset to actually manage these patients. I'm sure you will see a lot of snake venoms, all kind of poisons which normally don't come to large hospitals, lot of trauma. So this is the command center, and every command center, this is one block. This one block actually takes care of about 150 odd patients. So you have blocks and blocks of it repeating, and that is how the process flow happens. So the concept is basically what you're doing is this is a spoke ICU. You are connecting all the equipment that an intensivist needs, right from monitor to ventilator to infusion pumps if possible, because there's a lot of integration that needs to be done. And we put laptops on the scene, then we put some cameras, and we create a smart alert solution for that hospital. And this is linked to the local servers which are put at the hospital, and then it is linked to the command center which is currently based out of Delhi. So that's what the e-ICU process flow is there. So
obviously the first thing is to focus on clinical outcome, because it's a clinical solution. So if you're saving more lives, that is what the aim is. Best resource utilization. You have to establish some SOPs, because some baseline ICU mechanics must be existing before you can actually opt for an e-ICU, because you cannot have an e-ICU and say, no, I am running a 4 or 5 bed ICU, but I need e-ICU. No, the e-ICU can't intubate. e-ICU can't put a arterial line. e-ICU can't put a central line. So you still need baseline training of the doctors to actually do some level of ICU, so you can get them from A to C or from C to F. And that's what I told. This was the older command center. You do SOP implementation for error prevention, because I told you 10% of deaths are nothing but bad recognition of the events. You can't imagine how many of ventilator alarms in the night. And we have kept a very funny alarm, which is 100% FiO2. And our residents are in the habit of doing FiO2 100% in the night and ignore it. Yeah. So we kept FiO2 100 as an alarm, and we found that a lot of ICUs, they would just do the FiO2 to 100%, then just manage other patients. I'm not saying sleep off, but that's how they do it. So doctors are very smart in that way. So they sometimes they're quite funny. So a lot of things you have to do to actually prevent these errors. Smart alerts are very important, because it is color coded. It has to be color coded. The red one has to be acted immediately. So like tachycardia, bradycardia, hypoxemia, high plateau pressures are the alarms which are acted upon immediately. Then you have certain yellow alarms like rise in TLC or fever. These kind of things can take 6 to 8 hours to respond. But then there are certain alarms which need to immediately get corrected. It gives you a lot of insight, sir, into how the ACLS is run in our country. I have seen patients having ACLS at 45-degree head-up position and chest compression started by the doctor. But that's how it is. So
Patient also at 45 degrees?
Patient is at 45 degrees. So, but then, see, I don't see, that's the problem is the training. The problem is not they want to do it wrong. It's just that they don't know what is the right way to do it. And that's the problem. Anyway, so you have to make certain SOPs. You have to work on the smart alerts, because that is the pillar. You can't manage 350 odd patients physically. So the pillar is the alarm system, the alert system. So anything alert happens, what happens is there are 3 people in the command center. One is a physician assistant, one is a junior doctor, and one is an intensivist. The first job is to identify the alarm, see what the ECG is showing, open up the camera, talk to the doctor, and then that's how the system works. So it's not that you are monitoring physically every patient, isko kya hua, no. You just are working on the alarms. And then we make our own critical care list. So out of 300 odd patients, 30 will be most critical. Rest 270 will need to be monitored. But those 30 will be actively monitored. So those will be actively asked. So we take 3 times rounds in 24 hours. First in the morning, then in the evening shift, and then the night. And we'll keep on proactively asking for those 30. But rest 270 will be on the alert system. And that's how the system works. So if I talk about our benefits, 585 cardiac arrests prevented. And why I'll say prevented is because these are the patients who have had arrhythmias, who have had electrolyte imbalances, who have had hypoxias, and if you can actually intervene at the right time, you can actually do a lot of preventive strategies. We have done 25,000 high acuity consults. What are high acuity consults? High acuity consults are, you are seeing a ventilator alarm. You know that if this pressure alarm or a volume alarm is not catered to, ultimately patient will go into some kind of a complication. So or if you're seeing a atrial fibrillation happening, or you are seeing a blood pressure falling, or you are seeing a bradycardia happening, this is known as the high acuity alarm. So we do high acuity alarms. Then total patients seen till now is about 35,000. Look at the data. Look at the data that you can actually generate. You have seen this. This was a paper published by us in where we remotely did thrombolysis, because since we are based out of a Scott's Heart Institute, where if you throw a stone, it will hit a cardiologist. So we involved our cardiologist friend, because there are a lot of smaller ICUs where they didn't have a cardiologist, or a cardiologist was not ready to come until there's a primary. So we did thrombolysis through e-ICU, and this is published now in one of the journals. 620 thrombolysis. At that time when we had published it, was about only 80 thrombolysis. So we do thrombolysis through. So the benefits are basically in the form of prevention of arrests, doing early things which most of the small institutes can't do. So it does improve your capability to do those things, and identifying high acuity insults. This is the more or less the process flow. You can see the ECGs, as I told you, red and yellow alarms, which keep on coming, and you react to them, trendings, patient data, all those things. Impact, as I told you, the biggest impact has to be on the mortality. Why are you doing ICU? You are doing ICU to save lives, and that is what you need to document. So it does improve lives, and also reduces the cardiac incidence, as I told you. You can also look at softer predictors, like it does decrease the SMR, and this is the standard mortality ratio for one of our ICUs, and it's about 0.4, but more or less it is less than 1. And if you look at that, SMR 1 less than 1 is more or less a reasonably good ICU. And the mean Apache. So we track mean Apaches with SMRs, and this is the quality indicator sheet which happens for every ICU. You are able to decrease the use of anti-antics, but it's after a lot of resistance, because the e-ICU concepts are different. You are remote, you're not there at the bedside, and you just say, oh, stop this antibiotic. It's not going to happen. So it takes some effort, but don't aim for it. Implementation of standard care is, yes, it does help, because you are able to train them. Once you are rounding on the patient, the resident doctor on the other side also learns few things, and the next time he's more wise. After 15 days he's wiser. After 6 months he's actually able to understand your language. We were starting an ICU, I'll not name the city. We had put up 2 ICUs in the same hospital, and it was a heart failure patient, and I asked the resident doctor to apply a BiPAP. Now she has never seen a BiPAP, although it's available. So I opened up the camera in the other ICU, told her to go to the other ICU and take the BiPAP from there. She's standing in front of the BiPAP, and she's still trying to locate it. So then I told her, no, this is BiPAP in front of you, please take it to the patient and apply it. And it took us about 50 minutes to apply the BiPAP. But that was the first day. After 2 months, the same resident knew, now this is the patient. She would call more confident. We'll say, okay, apply the BiPAP, and she knows what to. So it actually is inadvertently helping people train also. Anyway, you can actually prevent ICU mistakes. You can actually do nosocomial control, and softer predictors like VAP, CLEPSY, we all track for all ICUs. We do it for regularly, but it does maintain the length of stay, can decrease VAP, CLEPSY, COTI, all those things. This was published in Global Heart. As I told you, the thrombolysis program, we have published cases in ISCCM, SCCM, e-ICM in the last 7 years. The rate of publications that we have done on e-ICU through India. Basically, I believe it has got a lot of role to develop, still evolving, very complex, because as it is, managing a critical care patient in the hospital is a complex issue. Imagine managing it through e-ICU is going to be further complex, but it is doable. It is doable, and it improves outcomes. This is where we are till now. As I told you, approximately around 12 cities. Nepal has been added now, and hope to grow further. Thank you very much.